to the CME. Respected Honorable President Sir Sharanji Karnik Sir, respected Shri Hemanji Karnik Sir, respected Dean G. Dr. Vikesh Bathiwala Sir, delegates, staff members, seniors and my colleagues. I, Dr. Devika Srivastava, feel privileged to extend a warm welcome to you all on behalf of Department of Oral and Maxillofacial Surgery, 20 Adultside Karnik Surgery Dental College in Howard. We are grateful to our dignitaries who have accepted our invitation to grace this occasion. Oral cancer is a debilitating condition that encompasses 85% of all head and neck malaria. The treatment of which is a multidisciplinary approach involving surgeons, radiation oncologists, chemotherapy oncologists, dental practitioners, nutritionists, and rehabilitation and restorative specialists. A radiation oncologist is an essential part of this multidisciplinary treatment team to treat cancer. Maxillofacial surgeons and radiation oncologists work in amalgamation to provide a complete holistic treatment to the patient. Constantly refining technological and treatment techniques in radiation oncology have benefited many patients with oral cancer, resulting in higher cure rates, fewer side effects, faster treatment times, and reduced rate. Today, we are honored to have our esteemed speaker, Dr. Rajiv Srivastava Sir, Senior Consultant Radiation Oncology from American Oncology Institute, as a part of celebration of International Oral and Maxillofacial Surgery Day in this CME. He is going to talk about recent trends in chemotherapy and radiotherapy in oral cancer. Also, I feel proud by reminding everyone that it happens to be the birthday of Dr. Jinwala Sir, our own renowned surgeon. Allow me to now introduce Dr. Rajiv Srivastava to the gathering. Dr. Srivastava Sir completed his MBBS from Ranchi in 1999 and MD in radiotherapy in 2005 from Varanasi. He is also PTCR from Catholic Clinic Institute. He has held different positions in medical academics across Maharashtra from 2005 to 2011. He has worked in Sevagram, Varda, RMC Luni, and Aditya Birla Memorial Hospital, Pune. He has also conducted and added several workshops and training programs, including at AIMS New Delhi and MGIMS Varda, along with several international multi-centric trials as principal investigator. Dr. Srivastava holds professional body membership in multiple occasions, has authored several publications, apart from sharing his expertise in this editorial board. Presently, he is team member of American Oncology Institute, Nagpur. This webinar is going to be streamed live on our college online platform and YouTube simultaneously. I request everyone to post their questions and queries on the chat box so we can take it one by one at the end of the session. Dr. Srivastava sir, this platform is all yours.
A very good morning, and it's a great privilege to be along with you. And thanks organizer to inviting me on this occasion and with all of you. So thank you very much, and I think you have to give me a screen sharing option so that I can.
Just 1 second, sir. Please wait 1 second. Sorry, just 1 second.
Yeah. Yeah, fine.
You may begin, sir. Thank you.
Yes, yes. I hope I am visible now. Hello. Can you hear?
Yes, sir. You are visible and audible also.
Okay, fine. Thank you. So, as we live in this part of country in the central India, and we all see too many cases of head and neck cancers due to the prevalent practices here of all those abuses which we all know. And in our day-to-day clinic, head and neck cancer is one of the most common patients who are coming and visiting our clinic. So all of us go through these patients and they come in different stages. And as was very nicely told initially, that the approach to manage any head and neck cancer is always multidisciplinary, where the surgical oncologist, the radiation oncologist, medical oncologist, the entire dental team, including maxillofacial surgeons, the rehabilitation persons, the nursing, the nutritionist, everybody plays a very important role in managing such patients. So, as I told you, that this is a multidisciplinary approach which consists of major three pillars: the surgery, the radiation, and the chemotherapy. For any cancers, these are the three major region or major approach towards treatment. And in particular, if we talk about head and neck cancers, the surgery plays a vital role along with radiation therapy. So today in my talk, I will be focusing on initial part because of radiotherapy. Because what I have observed in many years, that still the radiation therapy is least understood among all. We all know about surgery, we all know about different drugs, we know very little about radiation. That is not a part of curriculum in our undergraduate program. That is the most one reason we are here. And two decades, the radiation has evolved and it has gone into it is highly developed and targeted. So we need to think about it. So my in the initial presentations, I will be talking more about the initial basics of radiation therapy, what it is, how it is. Then in the later part, I will discuss about the head and neck cancers, what are the indications, how you should identify your patients, and I will conclude and then I will take your questions, whatever you have in your mind. So, as I told you, that head and neck cancer represents one of the commonest malignancy in our region, and the treating head and neck cancer is very complex. The most important problem which we all face is the lack of awareness. The people which are coming to our clinic are mostly coming in advanced stages, and that is the only problem which we are facing. Because if you talk about any malignancy, when you are treating a patient in the initial stage, the treatment is often very simple and the results are very good. The moment it becomes advanced stage, the treatment becomes complex, and the results are also not so good. So it is always a multimodality treatment. And whenever we are talking about multimodality treatment and the role of radiotherapy, radiotherapy is used in almost every cases except in early cases. It may be used as a definite form of treatment, it may become adjuvant to the surgery, or it can be used in the recurrent setting as well. So the common question is, which we all have in our mind as a doctor sometimes, and even as a layman person or as a student, because I think most of our audience are students here. So we always think, what is exactly radiation? We keep on hearing this term every time. But in our society, in our public, in our common people's mind, there are lots of misconceptions. So whenever we see people sending patient towards us in our clinic, or any patient interacting with us, they interact with a very different terms, which I will share with you. Like some patients come to us and they say that we have been sent to get a shock therapy, like some electric current is going on. Or some say we want to have a current therapy. Some say we want to have a light therapy, or we have been referred to get some light treatment. Or some say that radiation will burn my tissues or the microbes, because they sometimes think it is a microorganism, so it will burn it. But these are all misconceptions, and these are not the correct terms to describe radiation. Actually, radiation is just simple electromagnetic waves. It consists of photons, which are packets of energy, and definitely there are both ionizing as well as non-ionizing radiation, and mostly we are using ionizing type of radiations. So when we talk in a very simple word, the radiation what we use is mostly X-rays, and the difference between the diagnostic one and the one which we use in therapeutic is that the diagnostic one is in kilovolt range and what we use is in megavolt range. Being in megavolt range, it means the radiation will be more penetrating inside the body, and once it is more penetrating, it is going to hit DNA and it will kill the cancer cells. So when we use radiation, our aim is either curative or palliative. Depending on aim, it can cure cancer, where it is going to destroy all tumor cells, and wherever it has spread, either primary or the regional nodes, or it may be possible that the surgery has been performed and radiation is being used to take care of all microscopic diseases. Sometimes it can be used as a palliative setting when tumor has already in a very advanced stage and it is almost impossible to cure the patient. Then radiation can also be used in as a modality which can affect the quality of life and which can alleviate the pain and make the quality of life patient better, so that he can have some peaceful some period of time during his end stage of disease. So whenever we are using radiation in a radical setting, our aim is to cure the patient. And the most common indications are small tumors, or when we are aiming towards organ preservation and we are aiming towards maintaining a good quality of life and we want to have a good cosmetic outcome. Radiation, if you used in adjuvant setting, adjuvant means it is along with the some other treatment modality. So in adjuvant setting, like in post-operative treatment, when surgery has been already performed, so it is used to take care of the residual disease or microscopic disease to avoid the recurrence at local site or loco-regional sites. And when it is being used as a palliative modality, it is mostly used to relieve the symptom. Like if the patient has a bony metastasis, then severe bone pain can be taken care. It can prevent the symptoms or signs or morbidity. Like suppose patient is presenting with hemorrhage, so it can be used to take care of the excessive bleeding. It can also improve survival duration, like in brain mets, you can take care by radiation. So for the benefit of all my students who are now watching, the radiation, we always know radiation is there, it is going to treat your tumor, but they always wonder how it is. Medicine, injection, surgery, are removing the organ or cut, but radiation, what about how going to act? So when radiation is given to the patient, its target is the DNA. It breaks the DNA. There are two actions. There is indirect actions where it forms it creates active or reactive oxidative molecules, and they then put damages on the DNA, which can be double stranded, single stranded, depending on the type of molecule which is generated. And it can also directly break the bond in a DNA, mostly the hydrogen bond. So most of the radiation acts by indirect action, but there are also some direct actions. Now, when we talk about radiation therapy, there are basically two types of radiation therapy. One is the external radiation therapy and one is the internal radiation therapy. As the name suggests, external means the radiation source is outside the body. So we also call it teletherapy. And these teletherapy machines are capable of giving photons, electrons, or any particle like protons, neutrons. Then there is a brachytherapy, which is also called internal therapy. So here you can put some radiation source inside a cavity when it is called intracavitary. You can put in directly into the tissues when it is called interstitial, or you can put into any lumen where it is called intraluminal, or sometimes it is directly placed over some surface where it can be used as a surface molds. As such, the treatment approach towards any malignancy is multidisciplinary. Even in radiation therapy, it is a big team which is acting in the management of any radiation treatment for the patients. Of course, radiation oncologist, you all know who's the main person, doctors, who is planning the entire course, treating the patient, taking care of patient. Also, there is medical physicist who is taking care of the medical physical part, the machine part, and the radiation therapist, the technician is there, oncology nurse is there. So just for your benefit, this is the machine nowadays, that Linear machines, how it look like. Then just going towards little basic towards radiation therapy. The radiation therapy was discovered way back, and in the initial part of the radiation therapy, when it was discovered, people were very amazed about the product, like the radium, which was initially discovered due to its property like luminescence and all those things. They were thinking it is a very magic thing, and people were in the way back. It was being used to even paint the tiles of the walls at the time, and in those period there was not radiation therapy. These were dyeing paint over the tiles of the watch because they used to sharpen the brush with the help of their saliva. So unknowingly they were taking the radioactive material inside their mouth, and over a long period of time their jawbones developed reactions, and many of them developed leukemia, and they died. And when they started looking into it, slowly each and every property of radiation was discovered. And pioneer among the radiation we all know is the Marie Curie, who discovered many facts about radiation therapy. And in fact, whatever maximum thing we know about radiation is due to her contribution. So in 1951, the first cobalt machine was made, and still, if you look around in India, many cobalt machines are still active, mostly in the government setup. And here in cobalt machine, it is basically a teletherapy machine which houses a cobalt source which emits gamma rays, and they are in properties they are almost same like X-rays. But nowadays, when we talk about radiation, the thing has changed. It has changed drastically, and newer machines have arrived, computer has arrived, and everything has become targeted. So in the older days, when we used to, I will tell you, when I used to study that time also, there was no such linear accelerator. Linear accelerator was just making its way in the Indian market. So we used to have a cobalt machine, and the planning was very blind. It was based on surface marking on the bony structures. So you can see on the left side, we used to mark patient by bony landmarks. From there, Then the things evaluated, it evolved further, and the team started taking X-ray, orthogonal X-rays. So in that way, they were able to pinpoint the bony landmarks. And from there, now what we are doing is we are taking these CT scan, we are creating the 3D images, we can feed all those 3D images, we can recreate, and now everything is in 3 dimensions. So the first step is we have to immobilize the patient. Once we have immobilized the patient in various devices, we take patient to the CT scan, acquire the CT scan. Once CT scan, acquire additional imaging if required, like PET CT or MRI, whatever is required is taken. Once we have all images, then all these images are put into the treatment planning system. They are fused together to get the better overview of the target and the structures where we want to treat patient. And the 3D reconstruction is being done. Fusion, I have already told you. And once all these structures are present, we do the contouring. So the tumor is contoured in 3 dimension. Then all the organs which are in the proximity are contoured in 3 dimensions. Then once these contourings are being done, you can see on your screen, we are ready with the planning. So the plan is generated with a very sophisticated treatment planning system, which are very advanced computer system, which can generate the treatment plan, how you are going to treat your patient, what will be the outcome, how the dose will be distributed, what region is going to get a dose, like that. Then once we go through the dose distribution, then nowadays we have a very sophisticated QA and plan verification system. There are dummies available, there are phantoms available with multiple sensors. So we can actually put the plan on verification mode. We can check the point dose, we can have a point dosimetry, we can in advance before taking patient, we can be very sure about the treatment, whether it is having a good quality or not. So all tests are performed and patient is being taken for treatment. And over and above, there are verification systems even before treatment which can be done. So whenever we talk about radiation is normally a very small, you can say, treatment. It is general just for about 10 minutes. It is in general given in a 5 days a week, Monday to Friday basis, and Saturday, Sunday is taken as a week off. And normally treatment goes for 5 to 6 weeks, sometimes 7 weeks, depending on dose required. So common doses which is used in radiation therapy, we always tell radiation therapy dose in the unit gray. So palliative is like 8 gray in 1 fraction. Fraction means how many sittings you are giving. So 20 gray in 5 fraction, or suppose it is adjuvant therapy, 50 gray in 25 fraction, sometimes 60 gray in 30 fraction, or if it is a radical dose, it can be 66 gray in 33 fraction, or 70 gray in 35 fraction. Different fractionations forms are there. So in fractionations, what we are about to do is that the radiation which is intended to be given to the patient is not given in a single dose. It is divided into multiple small doses and delivered over a period of time. When we do this sort of thing, like fractionating the radiation dose, what we are doing is we are giving time to the normal tissue to get itself repaired. Because even if you are very targeted, still some of the normal tissues will be irradiated, and those irradiated tissue are going to give you reactions. So if you give sufficient time in between, they will have time to repair themselves. So normally we use 3 types of fractionation scheme. One is normal fractionations, one is hyperfractionations, then accelerated hyperfraction and hypofractionation. Normal means the day-to-day fractionations, what we are using. Hyperfractionations mean we are using more number of fractionations, And accelerated fractionations, we are not only increasing the number of fractionation, but also we are accelerating, means reducing the total overall period. And hypofractionations, we are increasing the dose size and reducing the number of fractionations. So by default, whenever we are treating patients, it is normal fractionation 180 to 200 centigrade or 2 gray is being used. And hyperfractionation, as I told you, we are giving more number of fractionations per day. So it is being used with the aim that if you are using more number of fractionations, more tumor which are proliferating in the radiosensitive phase, you can kill by giving multiple number of fractionations. But the moment you use hyperfractionations, you are going to increase your early reactions. There are two types of tissue normally. One is early responding tissue, one is late responding tissues. So early responding tissues gives very brisk reaction in the early phase of treatment, and the late responding tissues, they give reaction in the late part of the treatment or after completion of treatment. So whenever you are using hyperfractionation, there will be a brisk reaction, and early reacting tissues will react more. For example, the oral mucosa, they react very sharply, and you will form, they will have mucositis very early in the treatment. Then accelerated, as I told you, you can accelerate. Not only you can give the more number of fraction, but you can increase the you can decrease the overall treatment time to give the overall treatment very quickly. Hypofractionations, they are given for radioresistant tumors, where you increase the number of increase the total dose, but number of fractionations are decreased. Then there are split course of radiotherapy, just to prevent some mucosal reaction, where it is divided into two parts. These all type of fractionation scheme, what I have just give you overview, are being done to take care of the tumor type, because the different tumor have a different cells. Some tumors, they have a very high proliferation index, so they are proliferating very high rapidly. So in those tumors, we want to take care of the high proliferation index. That's why we give treatment very fast. But some tumors are such that they are more towards the resting phase. And if you talk about radiobiologically, the G2M phase, if you know the cell cycle, G2M phase is the most sensitive phase in radiotherapy. So if more number of cells are away from G2M cells, then they are more resistant towards your treatment. So if you use a large dose, then some of the cells may pass into the sensitive phase. Then there are other ways to take care of these problems, like some chemotherapy are being added, which acts as a cell phase blocker. So what we do, that we add some chemotherapy in the during the radiation therapy, and these chemotherapy act as a radiosensitizer, and they also act as a phase blocker. So they block a particular phase, and all the cells are which are in the dividing phase, they go towards the sensitive phase, which is the G2M phase, and that's why radiation effect becomes enhanced. So there are various ways depending on different tumors, and that's why different combinations are being used. Just to give you an overview of internal radiation therapy or brachytherapy, as I told you, there are interstitial, intracavitary, intraluminal. So nowadays a small machine is there which have a small source, and mostly nowadays we use iridium 192. So this source goes inside the patient in some catheters, and then they irradiate from within, and then they come out. So when we give this way radiation, the by physics, the inverse square law comes in. So radiation is highly concentrated towards tumor, and it rapidly falls off away from the tumor, and the side effects are less, because less number of normal tissues are being irradiated. Now, If you talk about voltage, like the older days, the initial machines were used was ortho voltage, which was in the 200 to 500 kV range. But these are very less penetrating radiation. So they are mostly concentrated towards skin surfaces and being used for mostly skin tumors. Problem with such ortho voltage radiotherapy is they in this range they are concentrated towards bone, and you will have more bone and cartilage necrosis. The osteoradionecrosis is more frequent. So these are not used nowadays in for head and neck tumors. And there are super voltage. These are all old terms. And nowadays the mega voltage is what we use. So mega voltage has a greater penetration. They does not depend on atomic number, so they will have no preference towards bone or soft tissue, and they have a very homogeneous distribution. So we don't have nowadays those incidents of osteoradionecrosis of the bone and cartilage. Now, once we are talking about radiation, there are different ways to deliver it. What we say is the techniques. So it can be in the three-dimensional conformal radiotherapy, it can be intensity modulated radiotherapy or image guided radiotherapy or intensity modulated proton therapy, stereotactic radiosurgery or intraoperative radiotherapy. So I will just give you an overview so that you will be able to understand what these terms means. So the older machines, they have a single energy. They are capable of giving only conventional form of radiotherapy, the cobalt one. So the cobalt machine is not capable of giving any newer form of radiation therapy. It is only possible in the linear accelerator. So the linear accelerator has wide choice of energy. Multiple energies are there, like 6, 10, or 15 MV. If you have more energy, you can have different penetration. Then you have a choice of multiple electron energies as well, and it is capable of delivering every form of treatment. So the most important revolution in the field of radiation therapy and the machine came with the invention of this multi-leaf collimator. This multi-leaf collimator is fitted on the head of treatment machine, and it has got multiple leaves, say about 120 pairs of leaf, which move independently, and they are capable of creating any shape. With the help of this, now we are able to create a different shape of beam which we can direct towards tumor. We all know tumor are not square or rectangle, which we always initially used to do with a square or rectangular shape of treatment. So it is always irregular. So the older days of treatment was in a square and rectangle fields, and nowadays when we not only can shape the beam, we can shape and vary the intensity of treatment as well. So just for understanding of students, the radiation machine has jaws, which opens in a rectangular or square shape. So this is the, you can see A, R, and the lateral are the two jaws, how it opens and make a square field. And then when we put a multi-leaf collimator, it creates a irregular field. And in nowadays, what we do, we make it dynamic, so it moves during treatment, and that's this way we can vary the intensity. And by varying using such type of technology, we are able to deliver different energy at different level as per our choice, and you can now take care of those problems which we face in the head and neck particularly, because it is a very complex. You have different contours, you have different organs present. Normal organs are there, the organ at risk is there, your target, different levels of nodes are there, and you have to treat giving different doses to these all tissues. So when we treat in a conventional form, you are going to irradiate the entire region. You are treating everything. So cancer or tumor tissue, the normal tissue, which is whatever is coming, everything is being uniformly irradiated. The moment you put a multi-leaf collimator, you can shape it, and when you shape it, you are able to take out some normal tissues or normal organs. Now, in the intensity modulated radiation therapy, the radiation therapy is split into very, very small beamlets, and there are different techniques. I'm not going to go in detail, it is too technical. But by directing different beams from different directions, or in arc therapy, you can create different dose gradient inside the body. And by that, you can have a very sharp demarcation between the tumor tissue and the normal tissue. And that way, we can now preserve different organs which are in the vicinity of tumor. For example, suppose when we are taking care of any head and neck tumor. So we all know parotid is one of the important, and spinal cord is one of the important organ in this region. And they react very, parotid react very early, also spinal cord react very early, and we have to save these organs while we are treating. So in the older days, it was not possible to treat these tumors without creating any problem with these normal organs. But with the technology, take care of each tumor, even if a tumor is like a C shape or D shape around the normal organ, still we are able to treat, and we can take care of the organ, normal organs with so the older days, what we used to do is we used to define the target, we used to have a volume, and then we do planning and treat. So it was called in a forward direction. Forward direction means that you are planning something and you are delivering it. But what is the outcome? You have to accept it, whether it is good or bad. But nowadays, everything has changed. It is now reverse direction. We call it reverse planning. So here, once we have defined the target, we have defined everything. What we do, we define what we intend to do. Means what dose we intend to destroy the tumor. What should be the maximum permissible dose to the normal organs. Once we have defined these goal, when by doing this inverse planning, we arrive at the best possible solution. What we can achieve for that desired result. So nowadays, the older days was solution defined as per the treatment beam. Nowadays in inverse planning, we are defining the solution and we are getting the optimal result, and then we in inverse direction to machine. So it's a little complex to you when I'm talking about all these terms, but just to give you a view, if you see in the image, this is a head and neck tumor being planned on a conventional therapy. So if we treat, you can see the parotid, the spinal cord, and the tumor, as well as pleural cavity, everything is getting a uniform dose. If you are treating everything uniformly, you will have all sorts of reaction, because parotid is going to react. You will have a permanent xerostomia. Spinal cord will react. You will have a myelopathy. So every organ, as per their function, they are going to react. If you do a 3D planning, you can conform it. Once you have confirmed, you can see somewhat you can shape your beam, and you can have somewhat normal tissue sparing. But still, it will be very difficult to spare overlapping organs like parotid, which overlaps on the overlap in most of the head and neck tumors. So parotid is going to have a problem even in 3D CRT. So the moment you put it on IMRT, you can now preferential dose distribute tumor and normal tissue. This way, you can save your organs and you can have a desired result without creating issues. Just to give you example of some tumors like nasopharyngeal, you can see temporal lobe is there, eyes is very close, the brainstem is very close when you are treating, and you go down to the same tumor, the spinal cord is there. Still, if you use the higher recent technology, you can very well create those gradient along the tumor. Even you can for all those nodal stations, and you can see very well You can shape a beam around the spinal cord in a C shape or D shape, and yet spinal cord is safe and your all nodal stations are getting adequate dose. Even in tongue carcinoma, you can see you can put your dose around the tongue and very well spare the parotid, the spinal cord. And the more sophisticated treatment is happening, the more number of cases are coming with recurrence nowadays. And in the older days, it was very well established that since radiation creates so much of complications, you cannot re-irradiate any patients. So it was universally told that if you take a radiation, then forget radiation for at least 5 years. You cannot take any radiation because you have already so much of dose around the critical organs, your body cannot tolerate a re-irradiation. But nowadays, when you have a such a conformal way of giving treatment, you can now re-irradiate even patients who have taken radiation recently. Then comes the IGRT. So IGRT is nothing that nowadays the machines are equipped with cone beam CT. They have a CBCT arm which can take CT scan, cone beam CT scan during treatment or just before treatment also, just before treatment. So we are using it for any setup error, interfraction motions or interfraction motions. These can be taken care. So if you have any moving target or you have a positional problem, or if you are thinking about tumor shrinkage or expansion, you can go for adaptive treatment. So once you have all these things, you can use image guided radiotherapy to take care of all these problems. Then nowadays you have your machine is equipped with what you called version, where the machine around 360 degree collimeter, they can move its multi collimeter, and this form of treatment is called volumetric therapy or rapid therapy. Then bring with the steroids that if you give a very high dose to a small portion of tumor, if in a very small tumor, you can like you are excising the tumor. It was successfully used in it is called stereotactic radiosurgery, and later on this was and it was being used by body where it was the stereotactic radiotherapy or stereotactic body radiotherapy, where very high dose of radiation can be used in a single fraction or few fractions to take care of a small recurrence or small tumor. You can directly use over tumor to almost ablate or incision has been done. Then although in head and neck we don't face such problem, but in other sites there are problem of breathing. Whenever is breathing during treatments, there so their target moves and it gives some error. So nowadays breath gating devices are available which can hear these breathing movements, and phase specific radiation can be given. It can be automated along with your treatment. Now, this was the overview of radiation therapy and is therapy. Now, when we talk about radiation therapy as a treatment modality, so it can be used in a pre-operative setting. Pre-operative setting means you intend to do surgery, but you want some of the tumor that you are able to do definitive surgery on that patient. So when such intention is there, so sometimes radiation can be used in a dose of say 50 gray, and this is called pre-operative dose. There will be no treatment delay, as inoperable tumors will shrink and slowly they will become operable. Then you can have a complete surgical excision of such tumor. You can reduce the tumor bulk, sick or they are hypoxic. If you reduce its bulk, it will become oxygenated and it will become oxygenated, and you all know that the more the tumor become oxygenated, you can now take care of it by using chemotherapy will have less effect, and radiation as well as chemotherapy, they give less effect towards such hypoxic tissues. Then suppose if any lymphatics is blocked, that can be taken care of, any disseminations, any microscopic can be taken with this. And it is but the most common problem with the preoperative radiation therapy is sometimes as radiation is going to shrink your tumor, the factor, while you operate such patients, the histopathological specimen what you will get will not give you definitive answers about the staging of the patient, because stage will change. Tumor has shrunken, the more advanced which was present there, like lymphovascular invasion or some other nodal invasion, that will disappear. So that histopathological specimen will be not representative of the initial stage of the disease. Now, suppose you are using a post-operative setting, that is within 6 weeks or and that is the period which is recommended. You should not delay your treatment beyond 6 weeks. So it can be used in 60 to 63 degree of dose to the primary as well as nodal sites. It's commonly used for any advanced T3 or T4 lesion or high grade histology, or if you have any peridural or vascular invasion, or if you are concerned about your margins or margin is positive, or if you have a nodal involvement. In those cases, post-operative radiation therapies are commonly being used. Also, the advantages of using in post-operative setting is that it allows complete surgical, histopathological, and biological evaluation, because before radiation you have operated the patient, so your specimen is representative. You can have a complete picture of its about the extent of involvement, any microscopic involvement or nodal positivity or any lymphovascular space invasion. All these can be very well represented. Then microscopic disease also you are able to judge your margins, you can tell, and your extent of tumor, you know your staging of the disease. But the problem with post-operative, what is commonly encountered is, suppose if there is any complication in post-operative period, that will delay your treatment in initiation for radiotherapy. And there are multiple studies which have already established that you have to start your treatment within 6 weeks. After that, every day lost, it is said that you are losing almost 4% of probability of getting cure or better outcome. That's why it is said that you should be able to send your patient or start your treatment within 6 weeks. But if there is any post-operative complication, this might hamper your treatment plans. Then there is also some problem of scarring and vascular modifications, if any, because for any radiation treatment, even for chemotherapy, oxygenation is one of the very important thing. So if suppose there is too much of scarring and oxygenation is hampered in the tissue, then you will have not so optimal outcome for these radiations. Now, if you are using it as a re-irradiation, suppose any salvage surgery is not possible in a patient who has come with recurrence, because it is always said that first you should try for surgery. If surgery is not possible, then go for re-irradiation. Then you have to see the previous dose, when the period, the area of radiation, the normal all organs, you have to evaluate, you have to judge radiobiologically the all previous treatment details and what is the total outcome of the previous. and based on all those judgment and all those calculations, then you can only consider patient for re-radiation. And definitely re-radiation is the most challenging task nowadays. So the most important factors which affects radiotherapy is the total dose. The more dose we use, the better will be the outcome. Then any concurrent chemotherapy or biological agents if you are using, any delay in starting treatment, as I have already told you, any treatment interruptions, and suppose if you are interrupting treatment in between, the local control will fall by 1.4% per extra day. So any anemia, because I told you already that hemoglobin and should be more than 12, and blood is very important. It is said that you can say that whatever damage radiation is producing over DNA, the hemoglobin, which is carrying oxygen, this oxygen molecule is the most important factor in fixing such damage. So if you have anemia in patient, the less number of molecular oxygen is available for fixation of such damage, and you will have less you can say less number of DSP or SSP, that is called double stranded break or single stranded break, which will be readily repaired, and such you will have a poor outcome with such patient if patient is in prolonged anemia during treatment. Then again, if a patient continues smoking during treatment, so carbon monoxide is more in his blood, and they displaces oxygen from hemoglobin, and accordingly less number of molecular oxygen is available for fixation of any damage, and so your effect will be less. Now with this background, we just talk about the general indications about radiation therapy in oral cancers. So we can use this radiation therapy in the primary, in T1, T2 lesion, in oral tongue, floor of mouth, lip, and we can use it as a single modality from external beam radiotherapy, or we can use it in combination with brachytherapy. In post-operative setting, there are some definitive indication you should always remember, like if patient has positive margins, if multiple nodes is involved, if any extra capsular extension is present. These are definitive indications for radiation. Then there are certain less indication, and it depends on number of indication or combination of different indications, like lymphovascular space invasion, perineural spread, any single encapsulated node which is positive, or any bulky tumors, because we know bulky tumors give more incidence of nodal metastasis. Then just to give you overview of the complications which are commonly seen in radiotherapy, again I will tell you the initial form of radiation therapy which was being used in the older days, like most of the things are you can see on your screen. These were prevalent in older days when the radiation therapy was not so confirmed. It was in a crude fashion through cobalt machine when we are delivering. So we used to see fatigue, hair loss, radiation sickness, mucositis, loss of taste, this permanent xerostomia, dryness of mucous membrane, skin erythema, candida infection, which is opportunistic infection, then any hemopoietic suppression depending on your field. Then the late reaction like permanent xerostomia, skin changes, decaying of teeth, osteoradionecrosis, trismus, pharyngeal stenosis, myelitis, retinopathy, or any radiation-induced secondary malignancies. But I will tell you, most of these are now have become historical. Nowadays, treatment are so targeted, you don't see most of these things. Although, depending on site, reactions will be there, but they are not so severe, which we used to have in the initial days. So there are certain guidelines which every patient should follow. But before telling you this, one thing which as you from the dental field, you should always remember when you are managing any oral malignancies, that whenever we are intending to manage any patients of oral malignancy, we should always remember that dental treatment is most important, and that should be given before any starting any treatment. For example, you should always check such patients for any caries or any dental hygiene or any sharp tooth and all those things, and whatever needs to be removed like caries tooth or bad tooth or any sharp tooth, it need to be done before initiation of treatment, because once you initiate your treatment and subsequent 6 month period, it is very difficult to do any such procedure. And even by mistake, suppose if you do such procedure, the healing will be delayed and you will fall into too many complications. So it is always advised, before initiating any form of treatment, do any dental procedures which is required for such patients, and then initiate your treatment, most commonly radiotherapy. So during radiotherapy, patient should have a good oral hygiene, balanced diet, brushing is important, flossing if required, then frequent saline rinses, then jaw exercises, and frequent follow-up, all those things are there. Then they should avoid spicy and coarse food like raw vegetable or any dry crackers or nuts. They should not drink very hot or very cold. They should not smoke. They should not drink. They should be away from any sugary snacks. Good mouthwash is recommended. They should sip regularly at regular interval. They can chew sugar-free candy to keep their mouth moist. They can ask their treating doctor for any medication if they have any complications, and they should take care of their oral cavity and their tooth. Now, as for your benefit, I will just add some facts about chemotherapy as well. See, radiation therapy, surgical therapy, and chemotherapy, these are three pillars for any management of oral malignancy. Surgical, you know, is the removal of tumor and the nodal sites. Radiation, I have already told you in detail. Now, regarding chemotherapy, chemotherapy finds its role in two settings. Sometimes you can say three settings. One is as an induction chemotherapy. Induction chemotherapy means you are having an advanced stage of tumor where you find it very difficult to go ahead with your surgery, or you cannot go ahead with your radiation due to bulky tumor. So there you start chemotherapy for the patient with a aim to reduce the bulk of the tumor. The bulk of the tumor will be reduced and inoperable become operable, or sometimes definitive radiation can be given. And the most common agent, alkylating agent, the cisplatin is very common, which is being now used. Then some patients, there are other drugs like paclitaxel is also very common. Methotrexate is being commonly used. There are combination chemotherapy which is available. So cisplatin 5 is the most common combination which is being used nowadays. Then it can be used as a adjuvant therapy. Adjuvant therapy means you have given your radiation or chemotherapy, your surgery, and you think there are some residual disease left which cannot be now taken further care. So you add chemotherapy as an adjuvant setting to take care of this residual disease. Then you can add chemotherapy in a concurrent setting, which I have already told you that during radiation you can add your chemotherapy in a weekly fashion, so that these chemotherapy act as block tumors in particular phase, and tumors will accumulate in the radiosensitive phase, and radiation will have more effect, more killings will be present. So it can be used in a concurrent setting. And further, if suppose the patient comes with metastatic disease or very advanced disease where you cannot do any form of treatment, then it can be used as a palliative setting where you want to palliate or decrease the bulk of the tumors. Now, in the field of chemotherapy, it has also advanced. Nowadays, monoclonal antibodies are available. The targeted therapy is available. I will give you examples nowadays that there are monoclonal which can target at particular mutation and mutations. You can choose a target, and as per your target, you can choose your chemotherapy so that it becomes patient specific or tissue specific treatment. So, uh, parallelly, along with surgery, radiation therapy, evolving, and more number of chemotherapies are coming, which are lesser toxic, giving lesser systemic toxicities. So every field is evolving, and nowadays is combination therapy, combination along with radiotherapy, surgery, depending on your stage to take care of any patient. Thank you.
Thank you, sir, for such a informative presentation. And only that, we have a few questions for you. So the first question is that how is radiotherapy decided in patients who have had recurrence?
The radiation dose is depends on two things. First is the tissue, which T about to treat. Is the tumor T. It is a squamous cell or it is a different whatever. So that depends on the type of tissue. Second thing is it depends on the bulk of the tissue or bulk of the tumor. For example, if you are treating any microscopic tumor, down to 50 the moment your tumor becomes macroscopic, you need somewhere around say 60 to 66 K. The more tumor bulk increases, you have to increase the dose. Accordingly, if a tumor is high proliferating, is less poorly differentiated, very sensitive to radiation. But if the tumor is well differentiated and more, they have a they are investing like sarcoma, they are radio, so you need higher dose. So it all depends. These combination of dosing, the fraction, all these are decided depending upon the amount of tumor bulk which is present and the type of tissue which you are dealing with.
So Dr. Ashish sir is asking, what is the role of amifostine and do we give it to the patient on a regular basis in our setup?
See, I will tell you a short background that during World War, Americans developed certain drugs which were developed in the hope as a radioprotective drug. The thing was they wanted that if there is a nuclear warfare, soldiers can be given certain drug. If inject, the bad effects of radiation will not happen. They will protect them as a radio protector. And later on, out of those different initial drugs, this amifostine drug was developed as a radio protector. So the aim of amifostine was to protect normal tissues and when you are delivering dose to the tumor as a radioprotective drug. The problem with the amifostine is that you have to give a higher dose just before radiation therapy. It needs to be preferentially distributed between normal tissues and it should not go towards tumor tissue. Although it happens that most of the amifostine goes towards normal tissues and a very less amount goes towards tumor tissue. And that's why when we irradiate such patients, their normal tissues are saved because these oxidative radicals are being taken care by this drug, and tumor tissues have a effect. But the problem with this drug was that you have to give in a very short interval of time. Immediately, once you have given the drug, you have to irradiate the patient. This was the first problem. Second, the side effects are very severe. And this was developed when the precision of radiotherapy was less. Means when you were using the more conventional form of radiotherapy. But nowadays, radiotherapy has evolved. It is such a targeted radiation therapy that you are able to confirm the beam and save your organs as such. And that's why this amifostine is not now no longer used. It is now gone. So previously, 5-10 years back, it was used sometimes in trials or some clinics they have used. But nowadays, nobody is using. I don't think because your radiation can take care. They are very conformal nowadays.
Okay, thank you, sir. So there is a question that can precision medicine be used along with radiotherapy?
Yes, there are trials where precision targeted chemotherapy is being used. I will give you one example of cetuximab. Cetuximab was developed and it is being used as a along concurrently along with radiotherapy. And the most important indication for cetuximab along with radiotherapy is in elderly people. Problem with elderly people are that the cisplatin, which is commonly being used as a radiosensitizer or in a concurrent setting, that it is very nephrotoxic. And in elderly peoples, there is it is all these compromised toxic acid, neurotoxic acid. So toxicity is very high with cisplatin, and there is also not younger patients. Most of the patients find that it cannot be met. There have one problem or a problem which will limit the use of chemotherapy. So in those peoples, it was found, particularly in head and neck cancer, this cetuximab can be used along with radiotherapy to take care of such patients. Available. The cost is of cetuximab still is very costly.
Sir, there's one more question by Dr. Ashish, sir. He wants to ask, do we have a stomatologist in our team to evaluate patient with head and neck before radiotherapy?
Pardon, repeat your question.
Do we have a stomatologist in our team to evaluate with head and neck cancer before radiotherapy?
Yes, we always, it is recommended that whenever you are planning any radiotherapy, depending on site, you have to have everybody in your team, stomatologist, the dental person, the nutritionist, the surgical, medical, everybody you should have a team. It is recommended that patients should go to everybody because initially the aim was only treatment, but now we are concerned towards rehabilitation of the patient. Patient should have lesser and lesser problem in post-treatment period. So patient should be checked and evaluated by everybody.
So there are a few questions from YouTube that we'd like to take.
Okay.
Sir, if the excisional biopsy is suggestive of an aggressive nature of the lesion, so when should we send the patient for radiation?
See, when you have done the excisional biopsy and your biopsy suggests that it is aggressive in nature, first thing before deciding radiotherapy, you have to do the complete evaluation of the patient. You have to evaluate the patient and you have to come towards the scene of the patient. of the patient regarding T status, N status, and M status. You have already said that is very aggressive. So you need to have a proper evaluation, and then once you have decided your stage, you have to decide that if you have done suppose excision biopsy, in all probability the patient will need a complete surgery means excision of the primary with margin as well as neck node dissections. Once patient has done that, then you can send your patient for radiotherapy. That should be within 6 weeks. But suppose if you are dealing with some tumors which is inoperable, for example of time or any laryngeal tumors, then yes, once you have done the excision biopsy, you have established the staging, then immediately send it for treatment.
Thank you, sir. Sir, between IMRT and IGMRT, which is better?
See, IMRT and IGRT technically are same except for image guidance. The IMRT is planned similarly like IGRT. But IGRT, there is a extra thing is image guidance. So the during treatment, just before the patient is about to take radiotherapy, the machine has an option of taking cone beam CT. So it takes a cone beam CT, it fuses this image with the initial image and then see the variation in XYZ coordinates. And if there is any variation, you can adapt, you can automatically correct all those errors, and then you treat the size, and it is image guided. That's why it is called image guided radiotherapy.
Thank you so much, sir, and thank you for answering the questions. I would like to request Dr. Ali Bansal to take over the diagnostic.
Thank you, Devika. Thanks to all of them said that duty is more. I'm delighted and my thank you. All of you on this occasion on Thursday. Well, I will thank our speaker, Dr. to share his knowledge for us. We are honored to have. I would like to extend my thanks to the team of American Oncology Institute, especially Mr. Ajay. I have seen that he is always keen to share their institute knowledge. Say I met him. Thank you, Mr. Ajay. I will be failing my duties, if I will not mention our worthy management, Honorable President Shri Sharadji Kalme sir, respected Secretary Shri Hemantji Kalme sir, and our respected Dean Dr. Digesh Barfiwala sir, who always take personal efforts to make every event possible. I would like to say thank to all the HODs of the respective departments and the students who participate in this program. This event would not be possible without my team and postgraduate actually are posted here. A big thank you to all of you. It has been a great learning experience. Thank you very much for being with us. Thank you, Dr. Ali. Shortly, I'm going to come and meet you. Thank you very much.
Thank you.